My research proposal is on vitamin D supplementation for the prevention of multiple sclerosis. With multiple sclerosis, there's a couple things that we do know as well as some things that we don't know. So multiple sclerosis is a neurodegenerative autoimmune disease. That means that over time it gets worse, and it's also a result of the immune system having an effect on the neurons in the brain on itself. It is diagnosed generally between the ages of 20 and 40 years old, so this leads to believe that it is probably developing somewhere earlier than the diagnosis time. It has a high prevalence in the area north of Boston, so looking at those northern latitudes, it tends to occur more. And this area also tends to have low UVB exposure, especially between the months of October and March. So in those winter months, we're not getting enough sun exposure, and that leads to less vitamin D production in the skin. So this goes hand in hand with seeing an increased prevalence of vitamin D deficiency also in the same population north of Boston. And we know that vitamin D plays a vital role in the immune system health. So all of these things lead to believe that vitamin D is playing a role in multiple sclerosis. However, we don't really know what's going on. We don't know the cause of multiple sclerosis, and there's currently no cure. So what this study is looking to do is figure out some of these questions. So we don't know what the optimal intake from vitamin D is to prevent MS, thinking about it coming from food. We don't know in terms of supplementation what the optimal dose is to prevent MS. And we don't really know what the optimal serum levels in your blood are of vitamin D to prevent MS. So this study here is looking to figure out what is a known minimum level of vitamin D intake from specifically supplementation that leads to a statistically significant decrease in the risk of developing multiple sclerosis later in life. So we're looking at supplementation during the really crucial years of development in youth, so before diagnosis, before age 20 to 40, supplementing, because supplementation is a really easy, cost-effective way to bring serum vitamin D levels up, and this could potentially have a positive effect on reducing the prevalency of multiple sclerosis. By doing this in the population surrounding Boston, we're helping a group that already has an increased risk of vitamin D deficiency and the disease. So this is a group that would really benefit from participating in the study. And the potential for a large contribution to the field really exists here. Like I said, we don't know a lot about multiple sclerosis and how vitamin D is playing a role here, but we do find these correlations that it could be helpful in preventing MS. And because there's no treatment right now for MS, prevention really is the most important thing. And if we can find an effective dose of vitamin D supplementation that prevents MS, like I said, this is a really easy way to potentially alter the course of people's lives that would otherwise have low vitamin D levels, suffer from MS later on in life, or potentially other issues related to vitamin D. So a really great way to intervene here is through just a regular oral supplementation. It could prevent needless cases of MS being diagnosed. And right now, there's no existing studies that looks at this. There's been some that look at serum vitamin D levels. There's some that look at latitude, that look at serum vitamin D levels in people who are already diagnosed, or supplementation in those who are already diagnosed. But specifically looking at prevention and what is the right dose doesn't currently exist. So this would fill an important gap that would bring clarity to people so that they have confidence and they could potentially take action in preventing this disease. Also, if we tend to see a correlation with either higher or lower serum levels of vitamin D, this could inform future studies as well as support broader recommendations, potentially raising the vitamin D cutoff so that rather than waiting until it gets really low before doctors intervene, it could be be monitored earlier on and potentially have a larger impact if we have a higher cutoff for where we start paying attention to it. And having those earlier interventions can just mean better treatment if it does need to occur. So looking more deeply at the methods and the procedures here. So like I said, we're going to be intervening at the critical development year, so between the ages of 2 to 18. We're not going to have anyone who is currently breastfeeding or is being breastfed because we want to keep the supplementation consistent across all the groups. So we need people to be able to chew and swallow the pills. So not exclusively breastfed infants will not be included. We also want to make sure we're keeping everyone safe in that healthy vitamin D blood level zone. So if it's below 20, they can participate, but we need to get that cleared from their doctor since we know supplementation is the correct course of action. However, if it's going to inhibit the treatment that their doctor needs for them, then they would not be included in the study. Also, we don't want to include anyone who's over 100 nanomoles per liter because this can get closer to that toxicity range. Looking at 150 or above, there could potentially be some negative side effects of having vitamin D supplementation. So keeping it in a more moderate range so that we can support healthy blood levels over the course of the study. If someone's currently already supplementing with vitamin D, they would also not be included because we don't want to make sure we're keeping the supplementation really consistent. If they had supplemented in the past 12 months, they would also be excluded. So only including those who have not supplemented with vitamin D specifically in the past 12 months and are not currently supplementing. Also, because adipose tissue can impact the amount of circulating vitamin D in the blood, we would only want to include those with a healthy BMI. The reason for this is because if someone is changing weight or if they have a high amount of adipose tissue and there's vitamin D being stored in that tissue and not being used, it could throw off the results that we're trying to figure out here. So this would definitely need to be something that another study would follow up on after the completion of this one. Also, we'd only be including those in the greater Boston area to make sure that we're keeping the latitude consistent. So looking at sun exposure, we want to make sure that we're holding that consistent since this has a big impact on vitamin D production in the body. So only people who live in this area would participate. And then also if someone is, say, tanning or traveling a lot and getting more or less sun exposure, maybe they're sick and staying inside the house, if it's drastically different from the population average, we would not include them in the study. So we want to make sure their sun exposure is pretty common for this area. The procedure of the study would begin with the finger prick test. This would also happen at intervals of day 90, day 180, 360, as well as this is about 3 years later. Or yes, so 0, 3 months later, 6 months later, 1 year later, and 3 years later. The finger prick is an accurate way to measure vitamin D levels in the blood, and it's super easy and would not require participants to come to the lab after that first visit. So this is something that they can do at home. We would mail the test kit to them along with their supplementation dosage so that they don't have to think about anything and it can increase attrition rate by having it available to them in their own homes. We'll be measuring serum vitamin D levels through this test. The doses used in this study would be a placebo dose, a 400 IU dose, a 1000 IU dose, and a 4000 IU dose. All of these have been used in previous studies and are known to be safe, but some of them you'll notice are much higher than the current recommendation from food, and this is what we want to look at to see if this is beneficial or not, while also monitoring blood levels to make sure everyone's staying within that healthy range. There would also be an app that would assist with reminders to take the supplement, reminders to complete the finger prick test. It would ask the question, did you take your supplement, so that we can be measuring adherence. Is it happening every day? Is it every other day? As well as a way to communicate with the study team. You can ask questions through the app, a very secure messaging portal. And then also once a week asking about sun exposure to see if there's been a big change from the norm. When we're looking at the results, we're going to be looking at the risk rate and the risk ratios. So you can see in this table here, there's one group of people that is potentially diagnosed with MS at some point in their life, as well as a group that is not diagnosed. And so after the completion of the 3 years intervention with the vitamin D supplementation, there will not be any required supplementation after that. However, the study team will be following up through the app, phone, and email once a year with the participants to see if they have been diagnosed with MS at any point between the ages of 20 and 40. So those who are diagnosed would fall into that column of the table, and those who are not would fall into the middle column of the table there. After that, we can calculate the risk ratios to see how many people are being diagnosed who receive the supplementation at these different dosages. And then by looking at the risk ratios, we can compare how many times more likely or less likely is the risk of developing MS compared to placebo, for example. So this example here on the right is comparing group A to the placebo, but we would also do this for between the groups to see is it more likely for a group with the 4,000 IU dose, are they less likely to develop MS compared to the 1,000 IU dose, or does it not really matter there? And in order to determine if this is statistically significant, we need to look at the sample mean and the confidence interval. So using the standard deviation of 0.95 and looking at the sample size here that we have, which is about just about 4,000. It's a pretty large study because we know there will be some attrition. The risk ratio must be above or below the confidence interval for statistical significance. So if we see that they're really close in value between certain groups, we know that there isn't a big difference in risk between those supplementation groups. However, if there is a statistically significant difference, that's a sign that potentially a higher or lower vitamin D dose is preventative for multiple sclerosis. Thank you.